I'm going to get started. So I'm going to try to go kind of quickly through this, and I'm going to talk about a retrograde tibial approach in patients with critical limb ischemia, a step-by-step approach to this. So as I had mentioned before, pedal access is another tool. It's another tool in order to treat these patients with critical limb ischemia, and it's really not as exotic as you think, or you may be tried to be believed that is as exotic. We have several experts here today that are going to go through treating patients with below-the-knee disease, and pedal access is just an alternative mode of treating these patients. It's an alternative access in treating patients with chronic total occlusions. It's very helpful in patients with ostial CTOs and prominent collaterals, even patients with superficial femoral artery and popliteal disease. Once you get comfortable with doing these procedures, as we are in our lab, we treat patients very routinely with SFA occlusions, especially ostial SFA occlusions. It's very helpful in patients with extensive collaterals in the SFA and popliteal arteries, and also if you can't cross in an antegrade fashion. So this is an example of an ostial SFA occlusion. This is difficult to see where you're actually getting into the ostial SFA, so it's very difficult to see. On the image on the right-hand side, you see an ostial or a proximal anterior tibial occlusion with heavy collaterals, and you can imagine that this would be difficult to get into that proximal cap because of the heavy collaterals. And another situation where you have heavy collaterals where you can't get into the popliteal artery to cross this, and this would be another nice patient to do a pedal access retrograde approach. So knowing the anatomy, and Dr. Zakir went over this, so I'm not going to belabor that. Access, if you're just starting pedal access, dorsalis pedis is probably your access of choice, and then the posterior tibial artery, and then peroneal artery is more of a high-end access, and you can use both and/or angiographic or ultrasound-guided access. In terms of angiographic guided access, the advantages is we're used to it. We know how to use fluoro. We know, sort of how to line things up with fluoroscopy, and it's helpful in with physicians that don't know how to use ultrasound. But the disadvantages are that you have issues with a lot of radiation exposure because you do have to use fluoroscopy. There's issues with patient movement because you have to use a road map, so if the patients move quite a bit, it is difficult to get access. Here you see access of the dorsalis pedis artery, which we did under fluoroscopy. The ultrasound-guided access is my method of access of choice because you have no radiation exposure. You have a higher level of detail because you can actually see the artery separated out from the veins. You can also see patients that have a poor flow into the dorsalis pedis artery because of a hibernating artery, but you can actually pick this up on ultrasound. The disadvantage is you have to know how to use ultrasound. So if you don't know how to use ultrasound, you're not going to be good at this. So here is an example of what the dorsalis pedis artery looks like. You see the artery is in the middle with two veins running side by side. And as you push down, if you're a little confused, where's the artery, where's the vein, you can put a little bit of slight pressure on that probe, and you'll see the collapse of the veins, and the artery will not collapse. This is what the posterior tibial artery will look like. You see the artery in the middle. It's a little bit more of a triangular position of the veins, and that's what you're going to be looking for when you access the posterior tibial artery. In terms of what you need for access, there's multiple different catheter kits and kits that are out there that you can use, but essentially you need a short micropuncture wire, and I use the Cook system, but there's a Terumo system, there's other systems. The nice thing I like about this is it's pretty low profile, and then you can put a hemostasis valve on it to inject dye. You can inject medications, nitroglycerin through that as well. So in terms of ultrasound, you can either use a hockey stick or a high-resolution probe. Here you can see we're lining up the arrow with our needle, and then you sort of line that up with the artery of access, and a little bit of practice goes into it, and that's why I encourage you to attend the pedal access course on Saturday, because instead of practicing on your patients, you can practice on cadaver legs. In terms of tips for success, what I've learned over the past few years as I've been doing this, pre-treat to prevent spasm. I always treat with papaverin. I give intra-arterial nitroglycerins if I have a sheath in place. And some people give verapamil. I don't really do that, but really papaverin and nitro is usually sufficient. I use a short micropuncture sheath so that you can really stabilize your hand on the foot as you're gaining access. And once you see that bleed back, flatten out your needle. And this is one of the most important things, is make sure your wire flows freely. Because if you're pushing against resistance, it should be very, very free. If you're pushing against resistance, you're in a dissection plane. And once you're in a dissection plane, you're going to shut down that artery, game over. My point is, just at that point, you're just going to pull out and come back another day, because you're going to cause more harm than you're going to do good. So here's an example of that. We have the needle in place. We have the wire in the dorsalis pedis artery that's it's very free, moving very nicely. Once you have this, then you can go ahead and put in either a sheath, or you can go bareback with a catheter or a balloon. And then you sort of have to decide, what are you going to do? Are you going to treat completely retrograde? So you can just, keep your sheath in place and then treat from a retrograde fashion, or are you going to flip the wire and then treat in an antegrade fashion? If you're going to treat retrograde, you want to go ahead and give some vasodilators, go ahead and give your anticoagulation at this point. In terms of retrograde intervention, you're kind of limited in terms of what you can actually do. You can do angioplasty, orbital atherectomy, and laser, pretty much what you're limited to in terms of retrograde intervention. If you want to use a directional atherectomy or a stent, then you'll pretty much have to go from antegrade approach, although there are some small diameter or some small French-sized stents that are just about to come out on the market. In terms of an antegrade intervention, let's say you want to do atherectomy or jet stream or something like that, then what you want to do is you want to externalize the wire, flip that wire, and get the soft end of the wire now into the pedal artery. And then this really expands your options, directional or rotational, laser, atherectomy, and you can stent, you can do pretty much whatever you want to. So in terms of flipping your wire, you can either manipulate it through the catheter itself. You can use a snare, as on the left-hand side, you can see we have the wire there. We catch it with the snare, and then we can pull the wire completely out. On the right-hand side, this is a nice little device. It's kind of fun to use. It's called a capture device. It's a reverse cone, and you inject through that. You have a little balloon occlusion, and then it really, really nicely goes into that device to externalize the wire. And then you pull the wire completely out. You flip the wire so that the soft end of the wire is now going antegrade down into the foot, and then you will remove your sheath. So you just have to manipulate that wire to make sure you're getting down into the posterior tibial artery here. And then once you get that wire down, then you'll pull the sheath out, and then after that, it's manual compression. Or you can use a blood pressure cuff, low pressure balloon inflation. That's kind of what I do nowadays, is just put a low pressure balloon up. I think last time I gave this talk, I said that I have my fellows hold manual compression and go out for a coffee. Dr. Miguel Montero Baker thought that was very rude, so I don't do that anymore. I just sit in the room with him while he's holding pressure. You can also use a radial band, as we did over here. They only come in certain sizes, so you can't really use it in patients that have big legs, but you can definitely use it in the patients that have smaller legs. Importantly, you have to know how to get out of trouble. So if there's a problem, you can really harm your patients. Just like if you have a radial access and you get in trouble from a radial artery access, you can really harm that patient. Minimize pedal time. Smaller is better. 4 French sheath is better than a 6 French sheath. Make sure you use vasodilators very extensively. Anticoagulation to prevent thrombus. Some people get afraid to overuse anticoagulation. You really can't, you won't do that. Remember, dissection is your enemy. Perforation is very important to be aware of, and if that happens, you can usually seal that up with a balloon inflation.
And we do it with passion to provide the best heart care close to home.
Should be
Alexian Brothers Heart and Vascular Institute. Our passion is powerful medicine.
It can be routine in your hands. It's not necessarily exotic. Access is key. Ultrasound guidance is my method of choice, and I think it's preferable over angiographic guidance. Use a lot of vasodilators, learn this technique, and use it frequently. Thank you.
All right, yeah. Check my messages. Hello? Hello? 1, 2, 1, 2, 3. We're at a party. Oh, all the way
I
to
was
10. 1,
taught
2,
by,
3,
I mean,
4,
I was
5,
asked by
6,
Jaafer
7,
to give
8,
you a talk about
9, 10.
how to wire complex below the knee occlusion. Do you have my talk on? Am I doing something
Damn
wrong
it.
here? Okay. Go back to the beginning, please.
All
Okay.
the skulls look nice.
Let me start with approaches for below the knee. Either we use transfemoral, it can be a bilateral, contralateral angiogram to start with.
This isn't bad.
I
Let's make sure
always
he's not
like to do,
bleeding.
a patient comes to me without any previous
is good.
angiogram.
I'm happy with
I
it.
always like to do a bilateral angio because you learn so much by looking at the other side. Actually, blueprint of occlusion is always on the other side. You look at the artery like this, superficial femoral artery, you see the other side is perfectly normal. So you know that you have arterial thrombosis here, and you have to treat it for that. Or you can do a ipsilateral on the patients that are obese or have an AVG. You feel more comfortable to go downstream below the knee, you can do a ipsilateral. Transpopliteal usually is used in retrograde fashion for treatment of superficial femoral artery, but we have done a few antegrade approaches on popliteal puncture due to infection of the groin or other problem. But it can be done in antegrade approach as well. And of course, tibial, transperineal, and pedal. These are the other speakers that talk about it, and will talk in detail. Dedicated crossing tool below the knee, none of these practically being used or indicated below the knee except laser. We use a 0.9 millimeter laser for recanalization. This is what I used. 90% of my cases are done with these wires and catheters. I don't use any other fancy recanalization tools. I use glide wires practically in all of my patients. I use both stiff and soft. I start with soft. And there are 3 hydrophilic catheters that we're using. And these are started with a quick cross, and this is customary in our business. When one company has a successful tool, everyone else is copying that. So a quick cross was the first one that came up with that hydrophilic catheter, then Trailblazer, and Crosscat. And Crosscat is by Cook. And they're all the same, except Crosscat has a little bit smaller tip. So there have been cases that I haven't been able to cross the quick cross or Trailblazer, but I've been able to do it with a Crosscat. So if you have very tight and calcified hard lesion, you may well go ahead and start Crosscat. Ask me to say how I use the wire. I don't know how I use the wire. I use the wire. This is a case that I did back in 1979. Probably was the first recanalization below the knee. I don't remember how I did it. I didn't even have the balloon, and this was done with one of the Van Andel taper catheter that I use for recanalization. But of course, today problems are we attack patients are the same, but we attack more complex lesions that previously, years back, we thought they were not amenable to angioplasty, but we do. The other complex case like this is occlusion of the popliteal, both anterior, posterior tibial, the tibial peroneal trunk arteries are occluded. How I did that? I used glide wire. You use an angle glide wire and wiggle your way through the occlusion to get where you want. Put a catheter over there, change it to a 014 wire. I see a lot of cardiologists use, to start with, 014 wire. But in some of these tough lesions, it's not going to work. I'm very much used to 035 system, and that's what I used even on very, very tiny arteries. So anyhow, this was a kissing dilatation of 2. As you see, we got dissection there. Then I put 2. These are smart. They're not smart. These are the old stents that used to use in coronary bypass graft. And as you see, the result is very nice and very workable. Now, you may have one lesion rather than 2 like that. Once again, occlusion of the distal popliteal extending down to tibial peroneal trunk, which is the peroneal artery, the main artery supplying the foot. It's very important that you'll be able to get this, but unfortunately, you think that's a very a simple case, but a recanalization didn't go right. I couldn't connect it. We use an outback, as you see here, to get into the peroneal and go ahead and do the dilatation. Now, there are patients who come with multiple vessel occlusions. This is a patient had surgery done for hammer-toe deformities, was not healing, was gangrenous, and when we did the angiogram, you see anterior tibia is occluded, posterior tibia is totally occluded, but fortunately, there are collateral arteries extending down to the plantar arteries from a peroneal artery. The main artery that we want to really work on is anterior tibial artery. Was approached with an angle wire, get into that, put a catheter over the wire. Then I use a lot of these straightforward occlusions in anterior posterior tibial arteries. I use straight glide wire because these are straight arteries, and straight glide wires does a fantastic job by cutting right in through the occlusion. Once the wire is gone through, I take that one out. I already have a channel, and I put a 014 wire through that. As you see, it's done here. This is a straight wire, recanalizing the dorsalis pedis artery. It's taken out, injection is made, and you see you have the lumen. You can put the 014 wire in and finish your dilatation. This patient, we have to stent the anterior tibial artery to get a result. And there was pictures of from 6 weeks, 3 months, and 6 months, and you see with a very nice result. This is a patient that is more complex, has ischemia of the foot, osteomyelitis second toe, the first toe, with the ulcer not healing. This is a letter from the vascular surgeon saying that how much this patient need amputation, referring to an orthopedic surgeon. And the funny thing is, he said that I told the patient how fantastic you are in amputation. So send the patient for amputation. Patient saw us, as you see here. I don't blame him for not wanting to do any bypass surgery, but we were able to, despite anatomy like this, we were able to recanalize, not only recanalize and do an atherectomy all the way down to the foot, and get an anterior tibial artery and dorsalis pedis artery very nicely patent. The patient went on and had a local osteotomy for osteomyelitis and total healing of the foot. Once again, more complex patient. That was the patient that the TMA was not healing. Now you have no runoff at all on the bigger arteries. There is a tiny distal peroneal artery. I used a loop technique. As you see on the first picture is the catheter with a tiny loop for recanalization. As you see, there is a dissection, dilated the whole thing, and stented. I had to stent the whole thing to keep that artery open for nice healing. And this is the, that was done in 1978, and this is an ultrasound in February 14, so that gives us 6 years patency still. Not every patient is going to be like that, but it is worthwhile to try. And even this artery get occluded, she already is safe. Getting further down to the foot, and this is a patient who needed amputation because of osteomyelitis. Dilated the recanalized anterior tibial artery, dorsalis pedis. Now you see the digital arteries and metatarsal arteries are very stenotic. Those were dilated with a good result. And the very last case is a case of posterior tibial artery down in the foot. Here is recanalized to medial plantar artery, but we need the lateral plantar artery. Now here I use the straight glide wire to recanalize the plantar artery, the lateral plantar artery, and recanalize that with very nice. So it's not really all the fancy devices that you ought to learn to use, and a little bit skill with the wire will take you a very long way. Thank you very much. In the
Amir, I think,
next speakers.
Live case. Actually, they're ready with the live case.
Or live case. Okay.
Can you hear us? Hello, hello?
Jack, can you hear
Calling.
us?
We can hear you. We're calling you from
Can't
Elk
hear
Grove
you.
Village. Can you hear us?
us?
Yeah, we can hear you.
Awesome. We can hear you now as well.
You can hear us?
We are
All right.
for you, Jack.
This
is
first a
How
word
do
from
you
our
put the power in
sponsor.
powerful cardiac care? At Alexian Brothers, we do it with some of the most advanced heart procedures in the nation, from minimally invasive to highly complex surgeries, with non-invasive rapid detection and faster treatment, and programs recognized for superior outcomes led by highly skilled
these
cardiac
people?
specialists. And we do it with passion to provide the best heart care close to home. Alexian Brothers Heart and Vascular Institute. Our passion is powerful medicine.
Hey, did you like that?
Yeah, that was, what was that? That's an advertisement for your hospital?
I don't know who those people were. They're professionals. Well, hey, it's Jack Chamberlain here. Can you guys hear us okay?
Good. Well, what do you have for us?
Oh, we have a fun case here. Now, do you have those little slides there? If you can put them up. Introduce our case. First of all, we're, like I said, we're from Alexian Brothers up here at Elk Grove Village. Want to thank everybody. Thank Alexian for letting us do this. And everyone in the room here, we have Mark from AV, which is really helping us a lot. You can't see him. Dave in front of you here. We got Danny, Mark, and Christine in the back. So our patient today is a 74-year-old gentleman. Actually had a heart transplant way back in 1998. I think we figured out that I may have taken care of him at Loyola as a fellow. It's a long time ago. But anyway, he came to us with a problem with his right foot. He was having some blisters about 5 weeks ago. And then he developed these kind of gangrenous tips. If you have those slides there, you can go to the last one there. I'll show you the picture of his foot. Do you have those, Amir?
Yeah, go ahead.
So he had an ABI done and really had a lot of monophasic flow all the way down by the foot. And we did do a CT, and he had a lesion in the popliteal, which we'll show you here, but he he really didn't seem like he had direct runoff. The anterior tib and posterior tib are definitely closed. The peroneal was a little hard to tell. It had a lot of calcium in the outside of the artery. But we have an angiogram for you now. Can you maybe show him our fluoro feed here, and we'll show you what we have. So can you see the whole thing? It looks a little
we can see
fuzzy
the
on this end for you.
popliteal shaft.
Yeah. Let me take the, hold on a second. We'll get the subtraction off here. So he's got, there you can see a little better. So he's got a tight lesion up in the popliteal in the mid, and another one after that. And then the runoff is a little bit better than we thought. He's got an ostial tibial perineal trunk lesion. Let me go forward to the other pictures we took first. Not that picture. And so there's our first shot. And the anterior tib was our hope to be our first focus originally. But as you can see, let me go back one shot here. The anterior tib is closed after a few centimeters, maybe 3 or 4, after the bend at least. Posterior tib doesn't get started. And at the foot, this peroneal actually stays open and feeds the dorsalis quite nicely, actually. So we decided that we should bring that back for you. Can you see that all right?
Yeah, we can see that very good.
So we thought what we probably ought to do first is take care of the popliteal and the tibioperineal trunk, get those looking better, and then I think we have an option to work with the dorsalis, the anterior tib a couple different ways. But we thought we should first get this going, because that's actually
Jack, can you hold on one second? I want to see what our panel would do with a case like this. Now you have a very nice reconstitution of dorsalis pedis. And so the question is, are you going to take a chance and recanalize the anterior tibial artery, or are you just going to stick with that peroneal artery? Let's start from the...
exactly.
Let's start from here. You're the...
Our guest.
Yeah.
Our guest from
Italy.
And pedo
Thank you
expert.
very much.
Yeah.
So I have a question before nothing. I want to know the indication for the treatment. So I mean, the patient presents ulcer in the foot. There is a TCPR2. Is a claudicant. Is a rest pain patient. Which is the clinical of the patient?
All you have to do is look at the slide of a picture of his foot with the gangrenous second and third toe.
Well, unfortunately, Jack, we never saw that picture. I'm sorry.
Oh, you guys don't have it?
No.
Ask Renee.
Yeah. But anyhow, we
Yeah,
take
what
your
issue?
word for it.
Okay. However,
We can maybe run the camera onto his foot.
No, we'll take your word for it, Jack.
Yeah.
However, there is a clinical indication.
So yeah, that's the issue.
There is a clinical indication related to the ulcers in the foot. So now the problem is to understand if the treatment of popliteal artery and TP trunk should be enough or not.
Right.
Jaafer, what do you do with that?
Yeah, no, I think that's a really good point. You know, we kind of go back and forth a lot with angiosomes, and you know, and I think we're going to get into that a little bit later on. But you know, as Amir said, you have a great collateral vessel supplying that dorsalis pedis artery via the peroneal. So I think I would focus on revascularizing popliteal artery. Look like there's a chunk of calcium there, the distal pop and the tibioperineal trunk, and then it's almost like a bypass leading straight to that dorsalis pedis artery and supplying flow to that foot.
Okay, go ahead, Jack. What are you going to?
Yeah, I would agree with that. When we saw the pictures just now and saw how good the collateral, how good the peroneal really looked and how good a collateral has to the DP, I would agree with that. I think if we can get these two stable and looking good, we'll give them a chance. I mean, and he may heal up just fine with that. So we're going to, that's what our plan was. So we're going to see if we can get this wired without any problems. I would like to protect the protect the distal bed, so I do want to put a filter down that peroneal because I want to do some debulking here.
Good
And the
idea.
calcium, someone,
What size filter you put in down there?
I'm going to put a 4 millimeter spider down there as our plan. It might be a little generous, but
Yeah, I
think it'll be
usually
all right.
use a 3 millimeter in those arteries and do very well.
Amir,
Go
are you?
ahead.
I mean, Jack, are you in with the crossover sheath, or are you antegrade?
we went antegrade. It was quite an experience. He's got a low belly, so we actually ended up sticking his SFA because his belly kept pushing us out. So yeah, we did go antegrade. And we have we put a 745 destination in antegrade, and because we wanted to be able to use a bigger cutter device on the popliteal.
And what kind of wire and catheter
And
are you
then,
using?
yeah,
What
we
type of
just
wire are
wired
you
this
using?
with a Miracle Bro 3, and we're going to put the spider down over this. In the I don't know if you can see what we're doing over here, but over my shoulder.
Well,
There it is.
Jack, I assume you're going to use atherectomy, and which one of the atherectomy you're going to use?
You know, I'm thinking a Silverhawk, the SX, we call it the sexy, what is it, XXC? We're going to use that on the TP trunk. I think it's a nice size for that. It's a pretty good TP trunk. And we should have enough room for the nose cone, you got where?
Did you
To
say
go down the peroneal.
Did you say
And it's a
LSM?
short, no, SXC.
Isn't
So
that
it's
a little
the
bit
smaller
too
vessel
small
version.
for
Well, it's bigger
popliteal?
than the old one, so.
Well,
But we'll
I
give
believe,
ourselves room if we need to
I
take the.
believe LSM worked very nicely there, and it's not a big, really device either. It will cut pretty good. I mean, popliteal is as big as SFA, so
Yeah, I think
Right,
that-
we're going to
that-
use a LSC on that pop. But we'll use a little smaller one below. But you're right. I think we could easily take 1 or 2 cuts out of that TPT with a bigger device and be fine.
I think you can use the same device
That's
in
it?
both areas. A trunk, you know, you have osteal lesion, you need a nice bite from there. And those tiny devices don't do that much cutting.
So you're saying you would use an L
Well, we'll see.
in the
You
osteotibial?
It's a big one.
Yeah, I would use LSM in both popliteal and the trunk, you know. The LSM is good from the vessel 3.5 millimeter up. So it's, you know, that trunk is at least 4. And I have used that very often, many cases, and no problem whatsoever. The little ones, you have to get them off the wire.
You barely get anything
Oh,
out.
those are
It's,
a pain
it's
in
too
the
small.
rear
Yeah.
end.
Larger headers are a little bit more aggressive.
Well, this is a different. This isn't an SS Plus or anything like that. This is a the SXC, and it has a plunger, and we'll get quite a bit out. We got an LSC available.
Jack, are you using heparin, Angiomax? Are you pre-treating with any vasodilators?
We did not give any extra vasodilators, but we'll probably give some nitro. And we're using Angiomax. So I'm going to do just a couple cuts on the pop just to get started and get so we're not held up by that.
Jack, I know you do a lot of atherectomy. What would be the role here of, do you think any of the atherectomy devices would work here, Jetstream, CSI? Is there sort of a reason that you chose directional versus the other two?
Yeah, you know, this is a short, focal, non-calcified TPT lesion. And I really think directional atherectomy does very well on those sorts of lesions where you don't have a long segment, you don't have a lot of calcium. The case we did before was the opposite, was just rock hard and really needed a diamond back and did really well with that. But this is soft, and I think we'll be able to get some work done. Well, we're not full at all, but we want to kind of see what we accomplished. So we just did a bunch of real short cuts on that TPT.
So, Jack, while you're cutting, I'm going to ask Dr. Polina something. So in Italy, do you guys use a lot of atherectomy or balloon instead? How would you treat this there?
No, we usually use more balloon angioplasty and sometimes drug-eluting balloon than atherectomy. But in these cases in which we need to treat popliteal artery, that is, I think, fundamental to avoid stenting, or to treat the ostium of tibial vessels, I think that atherectomy is the best indication.
And do you have all three available to you? Do you have all the atherectomy devices?
No, unfortunately, we have only silver oak.
Okay.
You know, if you did have heavy calcification, probably the CSI would have been a very good the atherectomy device to use, especially on that osteal lesion. But as you said, you know,
Right.
this seems to be a soft plaque, and so what you're using right now is the right device.
Yeah, and your initial angiogram after the atherectomy looked really good. That's some good results.
Well, remember that some of that is daughter
effect.
Yeah, because if you look at the popliteal
What?
artery, there is no significant
Daughter.
improvement. And if you look at the
Debulking.
specimen coming out, and you see that you didn't cut that much
Yeah.
either.
Yeah, that's a little bit more than doddering, though. That looks good.
Can't believe you accuse us of doddering this. All right, well,
Hey, I have to bring
why
his
don't
name
we?
up.
That's right. It's a requirement of all meetings. I'm pretty happy with that. Would anyone do any more to that lesion? Let's get the LSC.
Not your trunk, no.
No.
No, I'm happy with that, and I cut a little more lateral, you know, where there's a little bit there, and it didn't take much more out, but I think we'll be happy with that, and we'll try to clean up the popliteal some more.
Yeah.
And Dave's going to clean out the silver ox so we can prove to you we did do something. So hold tight here. You do that, and is the other one here? I'll hook up this way we're doing there.
You know, my usual rule of thumb for doing atherectomy is if I have, especially in calcium, if I have sort of those hills of calcium, I like to use directional atherectomy, especially because, or chronic total occlusion with heavy calcium, and you get through it, I like to use directional atherectomy. In terms of, sometimes you see those popcorn-type lesions called the boulders. I think that sometimes directional atherectomy breaks off those pieces instead of actually shaving it off, and using CSI is very helpful in situations like that.
You know, a calcified lesion is not only how much of that calcium you can remove, it is the modification of that plaque, that when you balloon that after you put in the CSI,
How we doing?
it's unbelievable how well they get
Can
dilated
we get this?
versus if you don't shave them at all.
We got to put it all together so it looks like more. Can you see this? We got to pile it all close together so Mir can be convinced. Oh, here we go. Up, down.
Here, lift it up a little bit.
Yeah.
Zoom in a
There.
little more. Can you zoom in?
Here, we'll make it look really big.
There we go. Not on your,
Right.
not on your
Not
head.
your head.
That's
you go.
huge. All right, we're going to go get the, we'll get the popliteal here. Go where?
So now you're going in with the larger cutter, Jack?
Yeah, this is the LSC. I use the calcium version because there was some calcium. It's interesting on the CT versus the angiogram. The calcium was actually a tad higher than the tight lesion. The lesion was actually a little softer, and it's kind of deep calcium, so it's not quite the boulder thing you were just talking about. So I think we'll get everything done, but I want to have a little extra cutting ability if we need it.
So Jack, how do you do, when you do
we're just-
directional atherectomy, do you go 8, go around 8 times with 8 cuts or 4? What do you like to do?
It's kind of like carving, you know. I try to go to where the resistance is, and I try to hit, at least the 4 quadrants, and then go off of those a little bit based on where the lesion is. The second lesion kind of looks concentric, so we're going to try to go all the way around if we can.
And
It's starting to fill up there.
you can't keep that cutter exactly where you want it. Most of the time you put them on the right side, they just flip. By the time you turn them on, goes to the other side. So there is also some limitation of how much,
That's packed.
how much you can direct that cutter.
Are you feeling any resistance as you advance that cutter, or is it going pretty smooth?
Fairly smooth. These last 2 cuts and that mid one got deeper. We got quite a bit of junk out of there, so it filled up the chamber pretty well. So. All right.
And one important point is that you don't have to try to remove every piece of the plaque there. If you do that, you end up with pseudoaneurysm. So just
Right.
good
some
luminal
nitro?
gain is enough to leave it for balloon dilatation to get a perfect result. If you insist
All right.
on cutting every piece of plaques, most of the time you end up with pseudoaneurysm.
So let's, speaking of that question, what do you guys think of where we are? Can you show them the fluoro? You didn't clean it yet. Well, that makes it harder to use it again.
Jack,
Is this
tell
it?
us
Is that the
what size balloon you're going to use in a popliteal artery. We might not be able to stay with
I
you.
wasn't really going to use a balloon. Do you think we should?
I think you should.
Let's find the other one.
Yeah, I always do, and
I'm
always.
gonna cut a little bit more first and
We didn't see that angio.
see if we get
Jack.
out of there.
Could you show us
Yeah.
what the angio looks
Oh,
like
can we?
after?
You showing this?
Yeah, let's see an angio now, because we have only about 45 seconds left.
Oh,
of
looks
your
good.
time.
45 seconds.
Yeah, Jack, how much time do you want? You should have been finished by now.
Rapid fire. You're worse than the manager here. Just kidding. Just kidding.
Well, that's a very good result for atherectomy.
really good.
I think if that was me, I would balloon that one and also that lesion above it. And put a 5 minutes dilatation, you're going to get a perfect artery, at least perfect looking artery.
Are you thinking to use a drug-coated balloon for this or not?
If we were in Europe, we would. They're not available yet.
We don't have it yet.
Soon, any minute. The other issue is, would anyone use Vascutrack or chocolate balloon or any one of those fancy balloons?
Not anymore.
Let's go back. Not
Unless you
How
want to
come?
throw your money away or make someone
Yeah, I know.
happy.
Yeah, they're
Okay, Jack.
significantly more expensive.
Wonderful job, excellent
you.
result, and we have to leave you now.
Great result, Jack.
All right.
Thank you. Thank you very much.
Thanks. We'll see you this afternoon.
Okay, I guess we go to you now, huh? This is a very, very interesting talk by Dr. Polino. This is a transmetatarsal approach for below the ankle angioplasty. I don't know if it's below the ankle angioplasty or the axis is below the ankle. But anyhow, very interesting topic.
I try to answer you. So first of all, thank you very much to the organization for inviting me in this fantastic meeting. And then my topic is the transmetatarsal access for below the ankle angioplasty, the clinical results. So let me to start with a short background that can introduce the ideas of this maybe exotic access. PTA is actually the mainstay in the management of patients with CLI. You know, everyone knows that this is related to the good clinical result. But however, there is a 20% of suboptimal success rate. In many patients, we are not able to engage the artery to cross the lesions or to deliver the therapy. And this is related to the type of lesions. CTOs, long CTOs, wall calcifications, and diffuse involvement of the foot arteries that compromise the distal runoff. So, in these patients, it's clear that we need in a lot of cases to treat SFA, popliteal arteries, tibial arteries, and foot vessels. Otherwise, we do not reach the result. We published many papers about this kind of extreme access. The last one was this in Endovascular Today, in which we report the technical tips and tricks, the indications, and the clinical result. Let me to show a couple of cases to let you understand what are you talking about. This is a case of 81 years old male, diabetes, hypertension, and obesity with a CLI with 18 millimeters AZ of TCPR2, previously amputated in the second toe, and today he presents a 3D lesion, tuck lesion in the fourth toe, so it's infected and ischemic lesion. This is the angio and the endovascular treatment. As we can see, antegrade approach in the common femoral with good SFA, just small lesions in the distal SFA, and stenosis in the anterior, occlusion of the, sorry, I need to come back, sorry. Is it possible to come back? Okay. Okay. Was wrong, the bottom. So as I said, short stenosis, small stenosis in the SFA, stenosis in the anterior tibial artery, occlusion of the posterior tibial, and in the foot, we have this situation, no plantar flow, and just tarsal branches, probably as we can see in the anterior posterior view, with the plantar dominance of the foot, so we can see the arch that comes from the plantar artery. So with a 4 French Bernstein and a V18, I approach the posterior tibial artery before interluminally and then subintimal, and we arrive really easy to the ankle, but then I found problems to dissect, so I was unable to dissect, and when I push, I obtain a big loop. So to avoid to broken the artery, I shift to this extreme axis, in which with a 21 gauge needle I was able to puncture the artery, I intraluminally deploy the V18 guide wire, and then retrograde recanalization using a CXI catheter. Then I connect both axes and pushing down the 4 French catheter. I check, I was intraluminally, so through this catheter I deploy a 014 guide wire, close the hole, close the axis, and then perform PTA of the posterior and SFA with this result. No flow limiting dissection, permeability patency of the anterior and posterior tibial artery with direct blood flow for the foot, for the plantar part of the foot, and again we confirm a plantar dominance of the arch with direct blood flow through the plantar artery and through the arch for all the toes. this was this clinical improvement to 55 millimeters Hg of TCPR2. Unfortunately, I can't show you the clinical result because, as we can see, is really is the case that I performed 2 weeks ago. So I want to show you the last one, but I don't have clinical result. The second case is a 65 years old male with diabetics, ischemic heart disease, again TCPR2 10 millimeters Hg, and a 2C lesion in the second toe. You can see the ischemic situation of this foot. And so this is the endo and the endovascular treatment. Again, if the video starts, it's possible to start the video, please. Well, seems not. What can we do? Okay. Again, was an access in the metatarsal artery. In this case, was performed to recanalize pedal and anterior tibial artery and produce, again, a good TCPR2 improvement. Again, it's really one of the last cases, so I don't have the clinical result of this case. But let me show the clinical result of the last patients of the last paper that I published about that. It's a cohort of 38 patients with this kind of risk factors, like all diabetic patients, a lot of the risk factors. And you can see this is, I think, really important. We use this access only to treat really extreme situations, so Rutherford 5 or 6 patients, clinical indication with ulcer in the foot. Otherwise, it's not indication to try to do some extreme access like this. And this was the baseline TCPR2 of our cohort. These were the results. So we treat 38 patients. We obtained a technical success in 33, in 86.8% of patients. And these patients were followed up for 30 months, more or less 1 year. The primary endpoint was the clinical improvement intended as TCPR2 improvement, and this was the situation. Pre-PTA was 10 millimeters Hg in average, and after PTA was 50 millimeters Hg in the average, with a statistical significant difference. But the most interesting, I think, is that no patients suffer minor amputations, and only 6 patients performed minor amputation that were transmetatarsal amputation in 3 and phalanx amputations in another 3 patients. But we need also to talk about the limits. As always, every technical strategy has limits. So the results again about amputation-free survival rate calculated by Kaplan-Meier, that was 84.1%. But all these patients, all these cases, this kind of access give us an increased rate of X-ray exposition. We calculate the X-ray dose and the time of fluoroscopy and compare this data with the patients treated only by antegrade access, and we saw that there is a significant statistical difference between each others. So I arrived to the conclusions. Digital artery access followed by retrograde recanalization provide good clinical result with a TCPR2 increment, support the amputation prevention with 100% of limb salvage rate and 84.2% of amputation-free survival rate at 12 months. We need to calculate that the limitations and the risk of X-ray exposition that was major in patients treated by digital artery access than the patient treated by antegrade. But today, with the ultrasound support, with dedicated proof, we can solve this problem. We are now starting to use a new machine in we are able to also perform the digital artery access under ultrasound. And with this, I finish, and thank you very much for your attention.
Thank you. Just one question before I get to the next speaker. Do you use any supporting catheter over the wire, or just use the wire with loop technique for recanalization?
Through the retrograde,
Yeah.
no, always use super
Only
catheter.
the wire?
No, super catheter, always,
What
always.
size catheter?
I use a V18 because I prefer for the support a 018 guide wire, and usually I use a CXI from Cook. That is very tough catheter with an angulated tip that allow me also to work without guide wire, changing the direction
Redirected.
in the curves, yes.
Yeah.
Yes.
Thank you very much. Thank you. Our last speaker of today is going to be Dr. Matthew Garofalus, and he's going to talk about the use of negative pressure wound, which I like to listen to that very carefully because I keep seeing all the patient coming with all these
Thank you.
devices on them. And go ahead.
Yes, well, after all the wonderful work that all of you do, then it's left to folks like us to go and finish it up, to make sure that they have a wonderful end result. One of the tools that we use to make that happen is negative pressure. Now, negative pressure has been around for a very long time, and what we do know is that it is indeed good for wounds. So after you've done your expert work in opening up the vessels to get blood flow to the limb, our goal is to finish off preserving it, and we like to apply negative pressure. We know that it helps with granulation, it controls the drainage, it improves patient compliance, and we all know that we hate to have a patient not be compliant after all this hard work has been done. There's many clinical benefits to negative pressure. Of course, first and foremost, it improves on what you've already done. It brings blood flow to that very aspect of the wound that we need to close. It reduces edema, it stimulates granulation tissue, stimulates cell proliferation, controls the odor, controls the exudate, and keeps the patient from interfering with wound healing, because as we all know, that happens many times. So there's plenty of evidence out there to support negative pressure, and while I didn't want to pepper you with reams and reams and reams of information, I just wanted to show you the latest study that was out there that looked at several other studies. And it was a rather large study encompassing well over 300 patients. And it showed that when you use negative pressure on distal limb wounds, patients achieve a wound healing closure rate 2.5 times more than if you were not to use negative pressure. So that, just this one study by itself, shows us that by using negative pressure, it helps us to close these wounds sooner. Now we've provided blood flow to that limb, now we're going to use some negative pressure, and we're going to increase the limb salvage rate as a result of doing that. Now, there's many types of negative pressure available to us out there. There's traditional powered negative pressure, which has been around for a very long time, where you either have to plug it in or it uses a battery pack, which is the powered negative pressure. And then there's the traditional wound care and the non-powered. And we're going to talk a little bit about all these things. The non-powered is the newest negative pressure out there, and it's called a SNAP system. We all know about the VAC, which is the powered system, and there's many other systems out there also. PICO by Smith & Nephew is another one. But the SNAP is out there, and we find that it increases patient mobility when we use this because they're not tethered to anything. It's very lightweight, and it works purely on mechanical power, not battery powered at all. And it has many, many applications. So we know that with the VAC, you want to make sure that the patient is compliant. You want to make sure that you have something that is non-invasive, that allows them some mobility. So whenever you can increase patient compliance by allowing the patient to resume a normal lifestyle, that's our goal. That's the goal that you strive to achieve with what you've done, and now in the wound healing phase of negative pressure, that's what we want to do also. So the VAC is out there. It's the standard of care, different interfaces. The SNAP is the more portable version. It works mechanically with a spring. This is just a small diagram explaining how the two systems work side by side. The VAC is powered. The SNAP has a spring mechanism. There's interfaces, and different interfaces can be used in a mixed form. You can use a variety of different foams with the VAC, with the traditional VAC, and even with the SNAP VAC. The SNAP comes with a hydrocolloid backing, but you can also use foam with a SNAP VAC, and we have done that with great success. It works as a wonderful interface. This is just a picture of the interface of the hydrocolloid dressing of the SNAP VAC, but you can also use some of the foam products between the wound bed and the SNAP VAC itself. So there's all sorts of benefits, of course, with a VAC because it's on 24 hours. As I mentioned earlier, application times don't take very long with these VACs, especially once you get your system down and you become expert at changing a VAC. It's just a matter of minutes before you can do it almost blindly, almost in your sleep. I mentioned earlier that there are some patient benefits to using this. Of course, decreased healing time is huge. Better ambulatory access for patients. They're able to move around. So we want to make sure that the VACs we use, both battery-powered and mechanically powered, are portable and allow the patient to assume their normal lifestyle as quickly as possible. It's also important that after getting revascularized, that they increase their mobility because it helps that also. So, economic benefits. There's economic benefits to these VACs because if we decrease healing time, we decrease cost. That's the biggest economic benefit that we have to offer. Meaning we know that with chronic wounds, they can often take a very long time to heal. And by applying a VAC, we now decrease that healing time, decrease the incidence of reinfection, reulceration, osteomyelitis, and possibly further amputation by using these products. Some of the mechanisms of actions on how the VACs work are cellular stretch. We know that because of the VAC, cellular stretch is implied, local perfusion, granulation tissue. Just to go over it very briefly, with cellular stretch, it helps to attenuate the inflammatory response and move that chronic wound into the next phase of wound healing. It stimulates the fibroblasts and the endothelial cells to increase proliferation. That by itself increases granulation tissue. We already know that when we apply a VAC with a suction rate of 125 milligrams of mercury, we are increasing blood flow to that area, which is exactly what we want to accomplish. We know that when we increase blood flow, we're going to increase granulation tissue. And as a result, we're going to increase the speed of wound healing and the speed of limb preservation. So we know that microvascular density increases. We know that we reduce those nasty MMPs from interfering with wound healing because with the VAC, they're whisked away and not left to meddle with wound care. So just to summarize, the VACs are important because we increase healing rates. We augment and we improve on what otherwise would be a very stagnant process. We improve the patient's quality of life. By increasing mobility, we improve their quality of life, which is something that's good for them and good for the wound. Also, because of recent advances in the coding world, we as providers are able to get reimbursed for application of the VAC, so that's always a good thing because that needs to happen also. So short and sweet, the VAC works, and we use it a lot in wound care. I would say over 50% of our patients are on some sort of a VAC. Thank you very much.
Thank you very much. We're running a little bit late, and I apologize to Dr. Noor for not giving her talk now. We'll have Dr. Noor give her talk in the next session. So we invite you to go on and get your lunch, and it's going to be here a lunch symposium sponsored by Gore about the stent grafts. Thank you for now. Okay.